I'm Dr. Michael Datola.
And I'm Megan Strong.
Is one of your kids complaining about a loose baby tooth? We've got your solution. That and more on today's Chairside Live. Welcome to episode 27 of Chairside Live. Megan, how are you?
I'm doing well. How are you?
I'm doing very good. Thank you for asking. We've got an interesting show for you today. We've got a good case of the week. I was walking through the implant department the other day, and I noticed something about the impressions on some stock abutment cases that had come in. So we're going to take a closer look at that in the case of the week. But before we go to that, we're going to go to a segment we like to call Viewer Mail. Today's letter is actually an email, and it comes all the way from China. And he writes, Dear Dr. Michael, how are you? I'm fine. Thank you for asking. I feel so lucky. I will get the chance to come to the United States as a visiting scholar to increase my professional knowledge and skills for about 6 months. I am a prosthodontist in the Guangxi Medical University and a dental technology teacher as well. Currently, our school has 240 professional dental technicians in college, and most of them know you from your clinical videos and from Chairside Live as well. Therefore, I hope to have the opportunity to visit your institution as a visiting scholar. Well, William, I can't pronounce his name. I'm rusty on my Mandarin Chinese, but in parentheses it says William. William, thank you so much. I'm not sure we will be able to have you here at Glidewell for a 6-month period. We haven't done something like that before, but it's always a possibility. But as somewhat of a consolation prize, I'd like to let you know that you're going to be the first one to receive the new limited edition photo of Megan and myself at our senior prom. And we will be sending this to you in China. I don't know how quickly you'll get it. Could be 2 days, could be 2 months. But thank you so much for writing in and sending that. And hopefully you will get a chance to stop by at least for a couple days once you're here in the United States. So thank you for sending that in. Let's go to Megan now in the news.
In the wake of the tragic Superstorm Sandy, 2 New York City dentists have filed a $5 million lawsuit against the contractor of a luxury apartment building. They are blaming the contractor for the collapse of the top of a construction crane during the storm on October 29th. The lawsuit claims the contractor was negligent because they failed to ensure the crane was properly secured before the storm hit. Both dental practices filing this suit are located within 1 block of the apartment tower and were forced to evacuate after the collapse until November 4th. One of the dentists had to close his office for the first time in 30 years. He claims he has lost a substantial amount of income from the closure. The other plaintiff says he was forced to spend thousands of dollars on lodging while he evacuated.
You know, when I saw that story for the first time, I thought, well, what does it mean that you had to close for the first time in 30 years? Because most dentists close every weekend and they close over Christmas, and so they're closed all the time. And I looked it up, and it turns out that the doctor is one who I've seen a lot on Dental Town, and I have a lot of respect for him, and he helps develop products as well. And what I didn't know is that he's an endodontist, and their endodontic office is actually open 24/7.
Right, I saw that in the story,
and so literally it's like there's a restaurant here in Los Angeles that has their claim to fame. They've never closed since World War II because they're literally open every day, all hours. And I didn't even know that a dental practice like that existed. And it's kind of neat because, you know, when you've got endodontists there who are doing root canals for people in a ton of pain, it's pretty amazing that in New York, in Manhattan at least, as a dentist, you can tell your patients there's a 24/7 endodontic practice here in case anything goes wrong with your tooth.
Right, 3 o'clock in the morning, come in no matter what. Exactly,
it doesn't matter, and it sounds like even on Christmas Day. And so this was the first time they had to close because of the crane coming down. And you can imagine in a densely populated city like Manhattan, they're probably a pretty busy practice. So the first time I read it, I thought, oh, this is just somebody trying to be opportunistic. But once you know the whole story, it kind of makes sense that they were forced to shut down for that amount of time.
Definitely.
Anything else?
Yes. When your child has a loose tooth, what do? Yank it out? Let it fall out on its own? Well, a daring father recently made waves in the news with his video of the unique way his young daughter lost her tooth. Let's check it out.
You know, I'm a little bit worried. I know we're going to watch the video here and see what happens here, but I'm slightly worried that publicizing this video, if it gets popular on YouTube, that parents, especially fathers, I doubt moms will ever do this, are just going to get crazier and crazier with their ideas about how to get a child's tooth out. And my fear is that we're going to get a dad who happens to see the Bruxer hammer test, and then the kid's got a loose tooth, and he starts thinking, yeah, exactly, that this would be a way to get it out. But I kind of applaud him on the other hand, because I always hate when parents bring their kids in to the dental office and they want us, you know, to take it out because they don't want to have that kind of conflict with their kid. And you really can't charge for it like you would an extraction, and you really can't get a syringe out and numb them up. And it's a difficult thing, and I always want to look at the parents and say, I'm going to leave you two alone in this room, and you're not coming out until that tooth's out of there. Here, I'll leave some instruments out for you,
there you go.
But I'm not doing it. You can't pay me enough to do it. So, all right, let's go ahead and take a look at that video.
Okay.
Wow, first of all, that's rough, making her hold the ball. She's the one with the floss tied to it. Oh, and there's the dentist.
Little Fido.
I don't know what breed of dog that is, but I don't know if they're renowned for their ability to yank body parts out. This poor thing.
Oh, here we go.
And, and it's out. Just like that. Wow.
Oh, no.
The dog didn't stop. See, kids, I want the kids to, oh, there's the blood. That's how you can tell it worked. It's just held on by a little attachment at the gingiva, so when it comes out, it bleeds a lot and it looks violent, but it's really nothing more than just like, you know, getting a little cut on your skin.
Now they're trying to find, where's the tooth? Did the dog eat it at this point? We're not sure.
Dog looks really happy. Dog wants to go after the other 9 remaining primary teeth she's got in her mouth. Oh, it looks like Sister went and got it, but I don't know. I guess the tooth fairy would still do some work and leave some money on something like that. But, oh, there it is.
There we go.
There is the tooth sitting right there, if Dad could focus on it. How did he get that on there? Is that crazy glued on?
I think it looks like he tied a knot around it, which that's slippery.
It'd be too slippery.
It
would come out. That's why I always thought stunts like this wouldn't work. It must be crazy. Maybe he's a welder, has a welding gun.
Possibly.
I don't know how he put that on, or maybe he crazy glued it. But I want the kids of America, kids, I want you to watch this video, because you'll note when the dog runs away and the tooth pops out, she doesn't cry.
No.
Because it doesn't hurt, and that's how quick it is. We've raised a generation of wusses, and videos like this are going to be a thing to turn that around so it gets better. Definitely. All right, thank you, Megan. Now let's go ahead and take a look at the case of the week. For this week's case of the week, I had an opportunity to drop by the implant department, and I noticed some things about stock abutments that I thought I would take a second to kind of point out. We're going to take a peek here and an impression on a stock abutment, and this is one where the dentist has done what a lot of implant reps will tell you is okay to do, and that's placing the abutment and then simply taking an impression of the abutment as though it were a tooth without the use of anything else. And as we zoom in here a little bit closer, you're going to see that it's difficult to really see the margins all the way around here because they're subgingival margins. I can see on the buccal over here on this side, I can pick up definitely the margin of the stock abutment, but as we rotate to the lingual, it disappears and I'm no longer able to see the margin over here on the lingual, and that's going to make it really difficult, and it's usually pretty easy to identify in the impression as well. You're usually able to see your margin part of the way, and then it just kind of disappears as we go over to the lingual. And so this is going to be an occasion where we have to call the doctor and ask for a new impression because we're simply not able to identify the margins all the way around there. An impression cap could have definitely helped this, and we'll get to a case like that in just a minute. I just wanted to share one more with you, kind of that same vein, where we've got a doctor taking an impression on a couple stock abutments. And again, on the stock abutments, it was taken as though it were teeth without any kind of impression cap being used. And it looks decent on the buccal, as we can see here. And then as we rotate over, again, we just kind of lose it on the lingual. And so, you know, you could say, well, could the doctor have taken a diode laser and cleaned up, troughed around the implants and cleaned up the tissue and taken an impression of these stock abutments? And I suppose you could, but really we just get a lot better result when we use an impression cap in a situation like this. The other thing about this, when you look at it, had this been an implant level or a fixture level impression, we would have had the opportunity to fix the draw on those two implants, especially that mesial implant. You can see the path of insertion really is leaning towards the mesial, and so even if you use a stock abutment like this, if you send it to us with the impression, we'll go in and fix that for you on the stock abutment. There's a small charge, but it's certainly not as expensive as using a custom abutment. So this is again one of those situations where it's just difficult to see those margins all the way around there. So let's look at a case where an impression cap is utilized. This is a case where an impression cap was utilized, and as a result we can definitely see all of the margins on the stock abutment as we look down, and we're able to recreate some nice soft tissue around that abutment as well, so that we can make a crown that's actually going to fit very nicely and also have nice emergence profile. And this is achieved by putting an impression cap on top of this and popping it down, snapping it on top of this stock abutment, and then taking an impression. When you pull the impression out, the impression cap will actually stay in the impression, and then we're able to put an analog in it and then pour it up in the laboratory. And really the big thing, the big takeaway here is that the act of putting the impression cap on the tissue shows you whether or not the tissue is clear. So on those two previous cases, had an impression cap been used, when the doctors went to seat it onto the implants, they would have noticed they couldn't get the impression cap down unless they went in with a diode laser and removed the tissue. So rather than taking an impression and then trying to see if you picked up all the margins on your stock abutment, it's actually easier to take the impression cap that goes with that stock abutment and try it down into place. Push it down into place and see if it'll go down. If it won't go down, the impression material certainly won't go down. And so on this particular case, this happens to be the impression the doctor took. I'll take that out of there. And that's the impression cap. It stays in the impression. It pops right off of the stock abutment when it's taken. And you can see as I put the analog in here, as though we're on the implant, it snaps into place. And so when you do it intraorally, that impression cap will snap down onto that stock abutment, and you'll get a really nice click, and you'll know it's in place. And then it's a much more accurate way for us to be able to, again, not only position this tooth in the arch, but because of the soft tissue detail that it gives us, we're really going to end up with a crown that fits well, has good contacts, and have very nice emergence profile because we're able to dial in the soft tissue so well. Furthermore, when we use an impression cap, it can actually go subgingival and push the tissue out of the way, so we can have a stock abutment like this that has subgingival margins, and we can still get accurate margins on our crown. In fact, you might look at this now and say, well, I see a little troughing there. It looks like you could have just taken it like a regular crown and bridge impression, but the only reason this troughing exists is because the impression cap was in place. So not only does it make the lab work more accurate and give us a better chance of getting you a good result, but it allows you to have a stock abutment whose margins are slightly subgingival, and we can still be able to read them and contour the crown to fit with the tissue. So really the use of the impression cap is a lot like the use of the two-chord technique when we're taking an impression of a regular tooth. The impression cap really assures us that we're going to get a nice result when we send the crown back to you. And without a doubt, really the best way to work with stock abutments is to take an implant or fixture level impression. So on a case like this, the doctor puts the impression copings into the implant, takes an impression, and then pulls the impression out and sends it to the laboratory. So here's actually the impression for that case. And you can see a nice full arch tray being used, 2 viscosities, and then the dentist took an impression of those 2 impression copings, and then he sends this to the laboratory with the impression copings, and we're able to pour up the model. And he also sent the stock abutments with it as well. So we're able to pour up this model, and then we can take the stock abutments that maybe he's already prepped those on the occlusal. In fact, when you send the stock abutments, we can see for sure where you've prepared it. Sometimes on a stone model, if you just treat these like teeth and take an impression, it's really difficult to see. And the stone itself, because the preps on when you take an impression like that are made out of stone, they scrape really easily. We really like having the actual stock abutments themselves, because if you didn't reduce enough on the occlusion, we can reduce a little more on those stock abutments. So it's kind of a cost-saving way to make it more like a custom abutment. You know, even though we certainly prefer custom abutments here in the laboratory to give you a better result, we understand a lot of doctors are going to use these stock abutments. So if you take an implant level or fixture level impression like this with the impression copings and then send the stock abutments here to the laboratory, this is about as close as you can get to working with a custom abutment without having to pay a custom abutment price. So I'm certainly not trying to talk you out of custom abutments. They're wonderful. I'm saying I know a lot of dentists like to work with stock abutments, and we certainly don't mind working with stock abutments, but I'm trying to give you some strategies here that are going to help you work with those. And you can see with the tissue in place, again, slightly subgingival margins, and that's fine. We're able to see that when we pull the soft tissue off of there and make those crowns, and then able to contour it to get some good emergence profile. So if I wanted to wrap this up, I would say if you're going to use a stock abutment, rather than treating them like teeth and taking an impression directly, call the implant rep for that system and get an impression cap to put on top of it. If you can't get the impression cap down, that's your sign you need to remove some tissue to be able to get that cap down. And once you get the cap down and take impression of that, the cap will stay in the impression, and that's a huge step towards us being able to give you a great crown that really has some nice contours, especially in the gingival third. And if you really want to do yourself a favor and make the case go quickly, you can use stock abutments, but again, if you take an implant level impression like this and then send us the stock abutments as well, we can pour it up just like this, and we can even do a little bit of extra work on your stock abutments if need be, if the occlusion hasn't been reduced enough or we have a line of draw problem or something like that. So the bottom line is we're more than okay working with stock abutments, but if you use an impression cap or an implant level impression, you definitely give us the best opportunity to give you a very successful restoration. That about wraps it up for this edition of Chairside Live. On behalf of myself, Megan, and everybody here at the laboratory, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time.
Oh,
the
really?
wow factor was so good. Oh my gosh.
I had no idea. I had no idea.
I was like, what the heck is this? And then I was like, oh my.
I had no idea. And I looked at Lindsay last night and said, do I do this at home? She goes, no. And so I was like,
wow.
Wow. So now it's going to happen. So then I started thinking, I can't run from it. I just need to make it a catchphrase. So I might do, whoa! Wasn't that Joey Lawrence?